Hi, this is the PCEP, October PCEP Skills makeup class, and today we're going to be talking about selective spinal immobilization. And part of this is so the whole point of this is kind of an evidence-based move in EMS to give some discretion when you're deciding whether or not to use full spinal precautions for a patient who is with mechanism of injury and possible blah. Hi, this is the October Skills PCEP 2013 makeup class, and it's on selective spinal immobilization. More about that in a little bit. First, we're just going to go over some things to remember when people are put in full spinal precautions. The medical condition of the patient and the need for the bullet points there on the screen. And remember that the patient position can impact their clinical status. Examples of this are patients that are third trimester pregnant or have underlying respiratory illness, COPD, CHF, or they're just flat heavy, the large bariatric patient. Those patients laying supine can exacerbate their symptoms. Other patient packaging considerations, environmental considerations. A couple of note are: don't hand equipment over the patient, don't step over the patient. Protect from heat loss. Consider sun and rain in their eyes and face. Properly secure your patient. And this is stuff that we've been doing all along. The use of straps. Headbed, remember torso first, head last when securing the patient to the board. And if you're going to have any kind of patient going to go in any type of vertical movement on the board, like up, downstairs, up, down terrain, consider using the purple webbing, the TRT strapping. Patient comfort, certainly a high consideration. Pressure points, void spaces, those things get uncomfortable over a period of time, so alleviate those or pad those. This adds to their perception of their care, good and bad. Fairly obvious. Patients tend to like to be in that reclining position on the gurney much more than they are lying flat on the gurney. So patients, when we can accommodate that, and there are examples that we're going to give later in this program that we can do just that. We can have the patient on the gurney just wearing a C-collar as approved by the MPD's office. And I'm going to go over those patients that you can do that and those that you cannot here in a little bit. We want to talk a little bit about bariatric patients. There isn't a firm number when you're bariatric and when you're not, but you're in that 300 to 400 pound weight category. Make sure you get enough lifters around the patient. That certainly can be difficult. If you have to do any structural modifications to get the people out of the structure, make sure to notify the battalion chief and make it a full incident. Maybe get TRT coming to help do that, so forth. It's important to remember to leave the gurney in the down position at all times. You don't want to create a top-heavy situation. You want to notify the receiving facilities early on that you've got a bariatric patient coming in. And remember to keep respect for the patient's privacy and feelings intact. You get the bariatric unit by requesting that through AMR dispatch. An FTO brings it to the scene, and you're part of that crew. And basically, you're just trading ambulances. That means that we stay there. We help load the patient. It's low tech. It amounts to a winch that's connected inside the ambulance, a cable, and a couple of ramps. Gurney's at the lowest setting. The gurney's rated for 1,500 pounds. Okay, before we talk about who can receive modified spinal precautions, let's talk about people who get full spinal precautions. Full spinal precautions with mechanism of injury present in anybody that has altered mental status. Evidence of intoxication, so that is the obviously intoxicated or somebody who's going to affect anybody that's going to affect their ability to readily locate pain and articulate that to you. Distracting injuries, those are such things as extremity fractures, fractured humerus, fractured femurs. The presence of neurological deficits, spinal pain or tenderness. This is as you palpate the spine. Comorbid age factors, less than 12, greater than 65. And this is in context, so this is a consideration. So this doesn't mean to say everybody in this age group. This means you want to take a special look at people in this age group and see if they don't meet any of these other rollouts, so to speak. You might have a 65-year-old patient with dementia. You may have a very healthy 65-year-old patient. So it's something to consider. It's not an absolute. Distracting situations, communication barriers, or significant emotional distress to a point that they cannot articulate to you whether or not they have pain. And again, a couple other considerations. If your immobilization technique, so you're going to want to put some. If you want to put, typically we put somebody in a neutral inline position. But if that causes increased pain or neurological deficit, position them in the immobilized position found or greatest comfort. And you don't necessarily have to do full spinal precautions for isolated penetrating injuries. So think gunshot stab wounds. Unless the initial injury penetrated or caused a disruption of the spinal cord, so either they have symptoms or they don't. If they don't have symptoms, you don't necessarily have to do spinal precautions. Other considerations: make sure you keep tabs of the patient's respiratory status during transport. We've talked about the third trimester pregnant patient. How you handle that is elevate the backboard 6 inches on the right side. And then pad backboards for interfacility transports. So remember to put the backraft on the backboard before you put the patient on it. More considerations. These are the patients that need full spinal precautions. Blunt trauma, altered level of consciousness. Spinal pain, tenderness as you palpate the spine. Neurologic complaint, anatomic spinal deformity. High energy mechanism of injury with any of the following. Intoxicated, inability to communicate, distracting injury. What's a mechanism of injury? Well, these are examples here. This is the algorithm that's in the protocol. We're considering patient mentation, our subjective assessment, that's what the patient tells you, and the objective assessment, that's your physical findings during the secondary exam. If you can answer yes to any of these, immobilize, full spinal precautions. If no, you can treat and transport without spinal immobilization, or modified is what we're suggesting. Semi-recumbent on the gurney with the seat collar only. So these are the patients that you can do the modified spinal precautions, selective spinal precautions. Patients ambulatory at the scene, patients requiring long transport, patients where long backboard not otherwise indicated. We still want to make sure to minimize movement and to guard against, take precaution, but not put them on a backboard where we can cause increased discomfort or pain. A little bit more about selective spinal mobilization. So we're in the past, it's always been all or nothing. You put on a C-collar, you get full spinal precautions. Now we're given the latitude based upon evidence. So as we move more and more to evidence-based medicine, that the evidence being that for a certain category of patients, their likelihood of having an injury based upon your rule outs from the algorithm is very low, and putting them on a backboard can make the situation worse, or at the very least extremely uncomfortable for the hour and a half they're waiting for the CAT scan to determine whether or not they have any kind of problem on their spinal column. So you're given latitude to evaluate the patient. If they meet the criteria, do the modified approach. If they don't meet the criteria and mechanism of injury is present, then they still get full spinal precautions. Just a couple of examples to make it more clear for you. The 6-year-old male who fell 8 feet off top of a jungle gym. He had a bump and some bruising above the left eye, an abrasion. He's conscious, answering questions, but becomes a little emotional and combative during your exam and attempts at treatment. So this is the patient who you want to do full spinal precautions on, but they are fighting against your attempts at doing that. And so they're ruling out C-spine right in front of you. Basically, it's making things worse. So you have the latitude to stop, not put that patient at full spinal precautions, encourage them to lay still, get somebody there who knows the patient, keeps them calm, and transport the best you can going in. This is not all situations, but if you run into that situation, you're given the latitude to do that and not feel that you have to, above all else, get the person strapped down. Example number 2, 75-year-old female, unwitnessed fall out of bed on a tile floor. She's got a laceration on the back of her head, a small amount of blood loss. She's conscious, alert, and oriented ×4. Her vitals are stable, and she's complaining of feeling dizzy prior to her fall, but has no other complaints. And so, as you've ruled out your mentation, the patient has got no mentation problem. She's alert and oriented ×4. She has no complaints, so she's got no subjective complaints. And on your objective assessment, that means you've done a physical exam, and as you palpate the spine, there's no point tenderness, no deformity noted. The patient can be put on the gurney in a semi-recumbent position with a C-collar on, and you can defer the backboard, the straps, and so forth. This patient here, with their history of atrial fibrillation, is probably a greater risk for a subdural hematoma because she's likely to take Coumadin than she is for a spinal problem. Alright, so this is a very common type of patient. Again, make sure that your mentation, subjective and objective assessment rules out the possibilities of having to do the full precautions, and then feel comfortable in transporting her in the position we just talked about. Okay, patient number 3. This is a patient who was in a high-speed accident, rear-ended, but was ambulatory at the scene. Conscious, alert, and oriented ×4. Answer your questions. There's no mentation problems. Subjective assessment does not report to you any pain. And on your objective assessment, you have no findings. Palpated the cervical, thoracic, and lumbar area, no point tenderness, no deformity noted. So in the past, we may have done a standing takedown onto a backboard with this patient and put him in the ambulance. This is now a patient that we allow to have the patient sitting on the gurney, semi-recumbent position with the seat collar on, and transported in that way. The lumbar pain, the lower lumbar pain and tenderness, that's noted. That's part of this history here is diffuse, so it's not point tender, no deformity noted, just generalized at achy back. Okay, so that's different. And then last, we've got our obvious example of full spinal precautions, a patient who was ejected from a motorcycle, 100 feet. He has loss of sensation, so he's got neurologic impairment. He has distracting injuries of a compound femur fracture and avulsion of a left finger. So here's your obvious full spinal precautions patient. Okay, so in closing, they're expected to do full exams on patients as we find them and to make some decision. We're given some latitude for decision making based upon studies that are being done that suggest that full spinal precautions for a certain category of patients is more harmful than good. And it's all based upon the algorithm. How is their mentation? Are they answering questions appropriate? They've got no distracting injuries, other distracting injuries, of significance. Their subjective history, they're not complaining of neck and back pain, and your objective assessment is that there's no point tenderness and no deformity noted. And those are patients that you can transport in a modified spinal approach. That's with the collar on the gurney, semi-recumbent position. Okay, thanks for your time. If you have any questions, feel free to call training, and have a safe shift.